Hello, everyone, and welcome to the 2025 Best of Lung Cancer Science podcast series from the Society of Thoracic Surgeons, where we explore the latest in science and innovations shaping our field. I'm your host, Dr. Erin Gillaspie, and today we're diving into the biggest lung cancer stories from the ESMO 2025 meeting and what those mean for thoracic surgeons. Joining me today are two of my favorite people, Dr. Jessica Donington, who is chief of the section of thoracic surgery and a professor of surgery at UChicago Medicine, and Dr. Christine Bestvina, who's an associate professor of medicine at UChicago. They're both on the ground for us at ESMO and are going to be here with us today reviewing the latest data. Jessica and Christine, thank you so much for being here. So much ground was covered at ESMO. Strong focus on advancing lung cancer research, which is always so exciting to see that we are one of the hot topics at every meeting these days. So many things are coming down the pipelines. What really stood out to you as significant, new? What really got you excited?
So I think the biggest thing is how cool ESMO is now and that more surgeons need to go. I mean, the last 2 years, we've seen so many really important things presented, and the Europeans throw a great party. So I think my biggest thing is to encourage American surgeons to go to ESMO because it's a good meeting.
Love it. Absolutely. They always choose amazing cities, amazing locations. We were lucky to be in Berlin this year, which is a place I've never been before. As far as some of the highlights of the data from the non-surgical world, just to give my colleagues some quick updates. As a medical oncologist, I would say that the most exciting thing that we saw in lung cancer this year was a drug called sac-TMT, which is a TROP2 directed antibody conjugate with a topo-1 payload. And this drug was tested in patients who have EGFR mutations with progression after osimertinib. Patients were randomized to sac-TMT versus platinum-based chemo, and we saw a doubling of median progression-free survival from 4 months to 8 months. And so this is a huge win in our lung cancer world. To see something actually beat platinum-based chemo is a big advance for patients with EGFR mutations. So stay tuned for where the sac-TMT story will go.
I think that's pretty cool because we know that everyone eventually develops resistance to our TKIs, and we've never had a good answer. I guess one thing I always worry about, Christine, in this population, how well tolerated is this drug? Because these are such young, healthy people. A lot of them are working. Is this something that they can take and still maintain their lifestyles?
Yes, you're exactly right. I think one of the big reasons why we've been so dependent on platinum-based chemo for so long is that patients can tolerate it. They can care for their families, they can work, they can commute, they can do what they need to do. Fortunately, with sac-TMT, we actually saw a pretty favorable side effect profile. So antibody-directed conjugates, while they are fancy chemo, they still are chemo. And that was reflected in what we saw with the treatment-related adverse events, where the majority of side effects were anemia, cytopenias, decreased white blood cell. And so I think for us, most of these are navigable toxicities when we're looking at cytopenias. They're things that we're used to managing. So I'm cautiously optimistic for how patients are going to tolerate this.
Wow, that is so exciting. Thank you so much for sharing that, because some of these very, very exciting drugs are very quickly making their way into the earlier stage space. And unquestionably, TROP2s are a very, very buzzy drug. ADCs are already making their place in early stage lung cancer. So certainly more to come there. All right, you guys, let's get into some of the hot topics, amazing abstracts and presentations that came out of ESMO. And we've sort of bucketed these into two major categories. And we're going to kick things off with ALK inhibitors. And so I think if people were not already excited about targeted agents in the adjuvant space, the updated ALINA and the Elevate trials, I think have really cemented the place of ALK inhibitors in the early stage lung cancer space, with a lot of excitement about these two presentations. Now, I'd like to kick off talking a little bit about ALINA because I think more people are familiar with this trial. And at ESMO this year, we were lucky enough to get some of the 4-year follow-up data. So Christine, if you can get us kicked off for our listeners, would you mind giving just a little reminder or rundown of the trial schema? How were patients, major sort of inclusion criteria, and what were the major arms of treatment?
Absolutely. So this trial included patients who have ALK mutations with resected stage 1B to 3A non-small cell lung cancer, and that's from the 7th edition of AJCC. Patients were randomized to either alectinib for 2 years or 4 cycles of platinum-based chemo. And I think this is really important because this is different than the ADORA trial in the EGFR space, where patients could have had chemotherapy, but then were randomized to osimertinib versus placebo. Here, we're really looking at platinum chemo versus alectinib.
I love that. Jessica, do you mind commenting just a little bit on some of the surgical considerations for this trial? Because just as a reminder, this is adjuvant. So there are mandated surgical aspects that are critical for consideration of enrollment to this trial. And I think it's really incumbent upon us as surgeons to continue delivering really optimal care to maintain the results as we move all of these trials into the real world space.
Right. So, I mean, you're only going to be eligible for a trial like ALINA or really for adjuvant ALK therapy in the US if you have stage 2 to 3 disease, which means you got to do a lymph node dissection. And if you don't do a lymph node dissection, your patient who may have, a real risk for recurrence isn't going to get this medication. So I think when we look at what's important from a surgical standpoint, I think that's it. That thorough lymph node dissection, whether that's a 3+1, whether that's 10 nodes, whatever it is, you got to do it. And I think we get a little caught up sometimes in sublobar resections. Oh, we'll just wedge it out. Oh, we'll do a sublobar, but it doesn't take away that. The other thing we have to do is to get your patient to adjuvant. You usually got to be careful about your complications, your length of stay, and stuff like that. So quality surgery really matters now that we have really good agents to give them in the postoperative setting.
Absolutely. And I actually want to drill down on one really key thing you said about all of the excitement around these sublobar resections. We see a lot of people starting to bend the rules just a little bit of how big the tumor should be and the exact location. And these trials did not include sublobar resections. It was a lobectomy, bilobectomy, sleeve resection with R0. So completely negative margins were critical enrollment criteria for this trial.
Right. I know. I really teach my fellows now that, we have 3 classes or 3 stages of lung cancer, or buckets. Maybe buckets is the best. We have early stage, which is like tumors less than 2 centimeters. Now that's early stage. And we think of those one way. And then as soon as your tumor gets over 2 and 3, this is kind of locally advanced disease. And you have to think like that. You have to think about what's the plus minus of not having enough margin or not having enough lymph nodes and all those things. And then obviously stage 2 and 3 is locally advanced. Those 2 are together now. 2 moved over, and appropriately so. It's, recurrence rates of 50% on its own. It's not early stage disease. How we used to have that on the other bucket, I'm not really sure. And then of course metastatic, which is a whole thing unto itself with its own issue, with its own discussions. But I really do think that when we think of early stage, it is only stage 1 now. And really that sublobar resection is really that 2 centimeter or less. And above that, you kind of really have to be thinking that this may be an aggressive tumor or a tumor where I may need adjuvant and I really need to get a good resection.
Absolutely. Absolutely. So in this beautiful trial, we enroll our surgical patients. They get randomized to these 2 arms, treatment with chemotherapy, placebo versus our ALK inhibitor, so specifically alectinib in this case. And ESMO, they share with us the 47 and 48 month updates respectively. And I think the 47 was our ALK arm and the 48 was our chemo arm. I'm not sure why they were just off a little tiny bit. But Christine, would you tell us about what those results showed?
Yeah, so in the intention to treat population, which included stage 1B to 3A, we saw an improvement at 4 years of disease-free survival of 47% in the chemotherapy arm versus 75% in the alectinib arm. So very importantly, only a quarter of patients had experienced disease recurrence at 4 years. So very optimistic that we are truly kind of helping cure patients and delay recurrence by using adjuvant alectinib for 2 years.
Now, talk to me a little bit about CNS disease-free recurrence as well, because that's one of the things that, from a patient quality of life standpoint, is a huge impact. How does alectinib perform in the CNS?
Excellent question, Erin. So we have known from the metastatic trials that alectinib performs excellent in the CNS. So we see CNS response rates upwards of 70 to 80% with alectinib. And so not surprisingly, when you use alectinib in the adjuvant space, you can actually prevent CNS recurrence or CNS progression from happening. So at 4 years, 90% of patients on the alectinib arm still had not experienced disease progression in the CNS. And that's really important for our patients. I always tell my patients the brain is their most important real estate. So trying to prevent cancer from spreading there is really important to these patients, both as far as quality of life and also longevity.
So, Jessica, I don't know about your institution, but I feel like obviously patients with lung cancer enter into all of our practices in highly variable ways. And for a lot of surgical practices, we can be the first stop right after either CT guided biopsy or, an interventional pulmonology endobronchial biopsy. How are you now navigating this space where we need biomarker testing on everybody? We need to be having, I think, as surgeons, conversations with our patients to say, hey, we might be talking to you about drug therapy, even though your tumor doesn't look very big right now. You're right at 4 centimeters. Historically, we might not have done anything, but now we have great drugs to treat you. Is that a conversation you're routinely having with patients? How are you guys handling biomarker testing? How can we as a surgical community do better to partner with our amazing oncology colleagues to find these patients and get them on these drugs?
So we have, or I personally, I can't talk for all of my partners, but I have the biomarker conversation very early.
Yeah.
Do I have it with every 1 centimeter nodule? No. But I start having it at about 2.5, and I'm definitely having it at 3 centimeters. Because, that PET might light up a lymph node. Why am I getting a biopsy? All those things are really important. So we start the conversation, I do very early, and I tell them flat out, there's new medicines, they're so good, but they're super personalized. We need to know what your tumor responds to. And, some patients are very tuned into it. Others look at you like, what are you talking about? But so we start early, and everything, all adenocarcinomas from our bronch suite all get, NGS automatically out of the gate. We've even convinced, some of our pulmonologists to draw ctDNA on patients who we think are really high risk, who look like they have clinical stage 3. We try to get that information as early as possible. Does it mean I probably biopsy more people than I did 5 years ago? Yeah, I get more pre-op biopsies than I did 5 years ago. But we also have more treatments than we had 5 years ago.
Christine, I want to drill back to one of the comments you made about the length of adjuvant treatment, because in the ADORE trial, people were treated for 36 months. In ALINA trial, were treated for 24 months, was a little bit different. And so 2 things that I think I really want to touch on. So number 1, obviously, earlier stage patients tend to feel a little bit better. They're super excited about their cancer being out. And sometimes there is a little bit less kind of feeling of necessity for staying on a therapy for longer term, right? People feel well. Sometimes they start having some side effects, no matter how well tolerated these drugs are. How are patients doing on alectinib? What are we seeing as far as dose reductions, interruptions, withdrawals? Are we getting these patients through these 24 months of therapy pretty regularly?
Great question, Erin. So I am super pleased with how well alectinib is tolerated. I actually find it's one of the TKIs with the fewest side effects. Some patients may experience some myalgias early on. We may experience some elevation in LFTs, but the large majority of patients tolerate this drug very well. And actually, I've experienced the reverse in my clinic where patients do not want to stop at 2 years. Patients are so hesitant to come off these drugs when it's working, when they're not having their cancer come back, and when they're tolerating it well and taking care of their families and working and doing everything that's important to them. And so I think that's the much trickier conversation, actually, is what do we do at 2 years? Should these patients be getting closer to 3 years like we did in ADORA? I think eventually we're going to be using ctDNA and tumor-informed ctDNA to try to assess who are the high-risk patients who may need lifelong therapy, but we're just not there yet. And so it's a tough conversation to have with patients.
Absolutely. Absolutely. And even sort of finding that sweet spot is hard. We have a little bit more data, more longitudinal information related to the osimertinib and ODORA trial. And it seems like there's a move right now to actually extend and see if perhaps 5 years is better than 3 years. Because as you mentioned earlier, Jessica, we do worry a lot about the development of mutations. Cancer is smart. It figures out ways to outsmart our therapies. And so a lot of us tend to think about some of these treatments as a little bit more kind of having a temporary duration of efficacy and needing to have second line, third lines available to us for our patients. And so where that sweet spot is going to land is going to be really interesting to see for all of these drugs.
I totally agree. I do remember, what was it, ASCO last year, we saw the LAURA trial report out for stage 3 unresectable patients, osimertinib instead of durvalumab after concurrent chemo-rads. And Alicia Sequist gave a beautiful discussion of how this is a systemic disease. This is really, we have to think of these as similar to stage 4 patients, because that trial, they stayed on forever and patients have done great. And I do think that in our resectable stage 2 and 3s, we're going to find that population and they are going to get treatment until progression, which I think is appropriate.
Many more ways to be able to monitor our patients coming down the pipelines, which is so exciting.
Yeah.
So OS data is still very immature right now. So really we're talking about disease-free survival for, the really, sort of early data coming out. It's really, really, really exciting. Any other thoughts on ALINA? What are you guys most looking forward to hearing about next with regards to this trial? Do we think that this is going to be another big hit moving into the neoadjuvant space with sort of a neo-ALINA type protocol? Where do we go next with alectinib?
I think you hit the nail on the head. I think neoadjuvant is the next most exciting space for ALK patients. I think NeoAdora, which is looking at either osimertinib alone, osimertinib plus chemo, or chemo alone, showed us that combination chemotherapy plus OC did very well in this group as far as pathologic complete response, but also the early signals of disease-free survival look very promising. And so I'm hopeful that we're going to see a similar win in the ALK space with a combination of an ALK TKI plus chemotherapy.
I agree. I mean, one thing that strikes you when you look at this trial, and the next one we're going to talk about, is how young these patients are. These patients are in their 50s. And so if we could really do something to increase their overall survival, that would be such an important thing. And because also treating them for life is hard because their lives are long. So I agree. I would love to see neo-ALINA that would set up a lot like NeoAdora, and I think it's really exciting.
Amazing. Amazing. So many more exciting things for our patients, which is just fabulous. So let's dive into our next trial, which is another ALK trial. So to have 2 at a major conference in the early stage, I was like, oh my gosh, this is just what a whirlwind. So the Elevate trial was another very sort of buzzy topic of discussion at ESMO. I think fewer people are familiar with this trial, really because it was primarily Asian-based trial with enrollment of 100% of patients. There really was not as international of a trial as we consider for something like ALINA. And I think fewer people are familiar with this drug. So actually, Christine, can you just kick us off by talking a little bit about ensartinib, which is the main ALK inhibitor that was used for the Elevate trial, and talk to us a little bit about some of the differences between ensartinib, alectinib, maybe drawing on some of the experiences in the metastatic space.
Absolutely. So ensartinib is a second generation ALK tyrosine kinase inhibitor. For those who don't think about ALK inhibitors all day, every day, as a reminder, alectinib is also a second generation ALK inhibitor. The further along we get in generations of tyrosine kinase inhibitors, the broader the coverage of that specific mutation and the better the CNS penetration. Ensartinib is probably slightly less good overall than alectinib. So at the risk of doing cross-trial in the metastatic setting, we see a progression-free survival of 25 months with ensartinib. And just as a comparator, we get about 3 years of progression-free survival with alectinib. And so just to start off, similar class of drugs, also an ALK TKI, but probably slightly less effective than what we would expect with alectinib.
You mentioned too that as we start to go down, we start to see maybe increased potency in a second generation drug, but also increased side effects. What are some of the most common side effects we see with ALK inhibitors?
So ALK inhibitor toxicity actually does vary quite a bit among the different drugs. And so alectinib, we had talked about, is generally well tolerated. With ensartinib, we tend to see more rash, as well as elevated LFTs, some constipation, an increase in creatinine kinase. And then just as a reference, we also have lorlatinib, which is a third generation tyrosine kinase inhibitor, which is incredibly effective. 60% of patients remain progression free at 5 years. That's incredible. That's mind blowing. But it does come at an increased toxicity cost, where with lorlatinib, we tend to see metabolic issues, weight gain. Patients have hyperlipidemia. The majority end up on a statin, as well as some CNS toxicity. And it can be anything from not being as sharp as you were before, all the way to hallucinations, actually. So quite a range of toxicity among these ALK inhibitors. And we're very fortunate to have many options with ALK TKIs that if a patient isn't tolerating one, we can potentially switch to another drug.
Absolutely. Oh, that's incredible. Thank you so much for sharing with that. I think it really helps to break it down nicely between first, second, third generations. Jessica, talk to us a little bit about the schema for this trial. Was it fairly similar to the ALINA trial? Were there kind of key differences that you noted?
I thought there was a couple of differences. I think this one mirrors ADURA a little bit more. So it was for, resected 1B through 3B patients. They had to have good performance status, and they had to have an ALK mutation. Then the patients could have chemotherapy. And then they were randomized between ensartinib for 2 years or placebo. So I think much more akin to what we saw in the ADURA trial, a shorter length of treatment, just 2 years. Then the primary endpoint was disease-free survival, as we see in most of these adjuvant trials. And the population, I would say, did marry ALINA a little more than ADURA, meaning, you're right, all came from Asia, but really young patients, mid-50s, heavily female, really healthy, and the majority had never smoked. So it was pretty much, I think, like ADURA. They were pretty well distributed between stages. A lot of 1B patients were included in this trial, which I think is a little bit different. And then similar to ADURA, like 60% of patients had done adjuvant chemotherapy. So I do wonder, when we see the results from ensartinib, whether that's going to bring the chemo question back up. Can it just be the TKI, or is there an option for TKI plus chemotherapy?
And I think that's also super important, Jessica, because I will say in my practice, for patients who are getting adjuvant alectinib, I do definitely offer them adjuvant chemotherapy first. And I think that's pretty standard across the country. As you had mentioned, these are young, fit patients. Offering them potentially curative intent cidal chemotherapy, I think, is really important. And so it's still very much a part of the conversation.
Oh, that's important to know for everybody too. And so are there circumstances in which you might consider just going straight to single agent TKI, sort of based on the ALINA results? Are you thinking more stage? Are you thinking more functional status? Are you thinking, age? How are you making those decisions in 2025, almost 2026?
So a lot of those decisions are based mostly on age, performance status, and comorbidities. So these are almost all patients who have adenocarcinoma. And so the chemotherapy backbone here would be a platinum plus pemetrexed, which is generally a very well-tolerated chemotherapy. But if patients don't have the renal function to allow for pemetrexed and they're looking at a more toxic regimen, that may be where we kind of stray away from it. If it's a 75-year-old who's otherwise very functional, I'd like to keep them super functional. Whereas I know sometimes chemotherapy can take away some of that kind of functional lifespan time from them. So definitely performance status, but also a patient-informed conversation. Patients have strong opinions about chemotherapy when they walk into my office. And so, patients are going to have an opinion very much about if they think the benefit of adjuvant chemo is worth the toxicity.
Amazing. Amazing. So we've talked a little bit about the trial schema, and really this presentation is focused on the first planned interim analysis. It's always great when we're getting a planned interim analysis as opposed to an unplanned. And this is looking at 24-month outcomes. So we're sort of about halfway where we were with the ALINA trial for comparison. We're at 48 months there. We're at 24 months here. Jessica, talk to me a little bit about the outcomes so far. How are the patients doing? Talk to us about disease-free survival.
It looks great. I think the results, while the curve may not separate quite as dramatically, the hazard ratio is still 0.2, which is like pretty impressive. And, disease-free survival was increased from 57 to 87%. That's pretty impressive. And then they did their subgroup analyses, kind of looking at which populations benefited. It was everybody. Chemo, no chemo, 1Ds, 3s, they all benefited, which is always kind of exciting to see that there's not a specific cutout. It was really, I thought, fairly impressive, like most of these TKI trials are.
Absolutely. No, I agree. I mean, it's pretty rare that we get to talk about hazard ratios of 0.2.
Because it was set up like a Dura. When you see the adverse events, there are way more on the TKI side, and that's because they were compared to a placebo with no other treatment. But they still look pretty well tolerated. Most of the adverse events are, transient rises in LFTs and things like that, which I think our medical oncologists are good at managing. So I thought I was pretty impressed. There weren't that many grade 3 or 4 toxicities. So I think people really do tolerate this drug quite well, as we have learned from the metastatic patients.
Absolutely. And I think a lot of these are very limited in duration, as you had referenced, Jessica. I think one of the things I'd love is for us to look at kind of, spider plots for toxicity. How long do these occur for patients before they stop? Because a lot of these will occur only with the first or second cycle with things like elevated AST, ALT, and creatinine kinase, and are not a chronic issue for patients, which is very encouraging.
And much like the ALINA trial, it didn't seem like we had too many treatment interruptions, treatment delays, or complete treatment cessations, which is always really encouraging as well.
Absolutely. I think, and sometimes those numbers are more important to me than rate of grade 3 events, which is, did this really force the patient to come off? Did we have to go down on the dose? I think that's such an important marker of true tolerability of the drug.
One of the things I always find so interesting in these trials is because we have a lot of placebo arms and we have reports of toxicity in both arms. So a drug-specific arm that has a 98% toxicity rate, everyone gets sticker shock, right? But then you look at the placebo arm and it's high there too, which I think is a really important reminder that patients with cancer who have been through surgery, who are on treatment and coming to the doctor's office all the time and being asked 1,000 questions about every little thing that they feel, things are going to come up that are positive, and 98%, adverse event rate doesn't mean that a drug is completely intolerable. And I think that's really important take-home message as we talk about some of these drugs, because you can look at that data sometimes and really it can be very surprising. But it doesn't mean the drugs are intolerable, which is so great to hear.
Yeah, I know in all our adjuvant trials, there's a lot of placebo toxicity. I agree. Our patients are tired. They've been through a lot. And people are asking them questions. Does your back hurt? Yeah, my back hurts.
Mine too.
I even had a lady who, you're right, she's doing actually pre-op treatment, and the same thing. She's like, yeah, I have headaches and and my stomach hurts and this and that. She goes, but I don't want to stop this drug. Let's go. I'm ready for more. Like, okay. So yeah, do I have the problems? Yeah. Can I live with them? Yeah. If it's working, I'm going.
Yeah, and getting to show these curves and tell patients, hey, we can make a huge impact in your quality of life from a lacking CNS progression, tolerability standpoint, disease-free survival standpoint. That's a lot of holidays with family, which is something that we're all aiming for our patients to have. You think about it a lot more this time of year, but really wonderful for our patients. So we've alluded to it a couple times. The Elevate trial, 100% Asian enrollment. ALINA is about 55, certainly a much more representative international trial. Is this data broadly applicable? So can we take the Elevate trial? Are these the same patients? Can we apply that data to our patient population yet? Or do we need to say, okay, we're not ready for ensartinib in prime time yet. We need a little bit more data. We need a little bit longer disease-free survival follow-up. How do we take that trial? We have, a great drug in alectinib. What are you doing, Christine, in December of 2025, thinking about a patient who's in front of you has had a great surgery, ALK mutation? How are you going to think about treating them?
So I don't think this trial is important as far as I'm going to now prescribe ensartinib. I think we have alectinib, which we know from the metastatic setting is likely a better TKI in this setting. Where I think this is really kind of practice affirming is that we now have a second trial in the ALK mutated space that showed very similar results. So, ALINA was not just a one-off. This is going to be consistent across TKIs. And also just in kind of confirming many of our practice of giving chemotherapy before we start the ALK TKI. So that may be actually the more practice changing part of this trial is just, again, confirming these patients should be offered chemotherapy before their ALK TKI.
I guess I think of it a little bit, in the immunotherapy space, we saw NeoTorch and Rationale 315. Those were trials run in Asia using actually medicines only really available through Asia. And you're right, is it enough to make us want to use toripalimab or tislelizumab? Probably not. But do they make us feel even better about what we saw from Keynote and Checkmate and all those trials? Absolutely. So I think I would say, just because it's not necessarily done in the West doesn't mean that it's not good science and doesn't reaffirm with the medicines that we use here.
I love that. 2 incredible trials completely cementing ALK inhibitors in the adjuvant space for our certainly stage 2 and stage 3 patients. Question mark, maybe stage 1B.
There are 1Ds in this trial for sure, and they seem to get a benefit. So
Absolutely. You guys, let's completely switch gears. And Jessica, you could not have given a better comment to usher us into talking about immunotherapy. I feel like this has been the darling drug of really every cancer. It has impacted how we think about treating so many cancers across the spectrum from early stage to late stage, and really has transformed survival for our patients in such an exciting way. And undoubtedly, it has been so exciting in the lung cancer space with our Checkmate 816 trial, Checkmate 770, which we've had the privilege of talking about with some of our colleagues in the other podcasts. And I get to talk with you guys a little bit more about the Keynote 671 trial. Now, we have talked about that a little bit before on the Thinking Thoracic podcast and our Best of Lung Cancer series, but honestly, I think repetition is so critical for us understanding, remembering these trials in great detail. So Christine, if you don't mind kicking us off this time, can you talk a little bit about this trial's schema, how they sort of thought about enrollment? There are some subtle differences when we think about chemotherapy in this trial, when we compare Checkmate 816 to some of the perioperative or periadjuvant, different numbers of potential chemotherapy regimens in the neoadjuvant space. Give us the summary and breakdown of Keynote 671.
Absolutely. So this is a trial looking at perioperative pembrolizumab. So in the intervention arm, patients could receive 4 cycles of chemotherapy plus pembrolizumab. Then they hopefully got their surgery, and then they got adjuvant pembrolizumab for 1 year. Versus the control arm where patients got neoadjuvant chemotherapy, surgery, and then placebo out back. And so for patients, it looked at kind of pembro both before and after surgery versus just chemotherapy before surgery. A few of the differences that you alluded to. So here we saw 4 cycles of neoadjuvant chemotherapy immunotherapy as opposed to 3 with Checkmate 816. There were some differences in which chemotherapy arms were allowed on the trial. I think more than anything, it just gives us a little bit of flexibility in what we can offer patients in choosing our chemotherapy backbone for this. And excited that we now have 5-year survival data.
I know it's actually hard to believe that this trial has reached the 5-year mark. It feels like just yesterday we were starting some of these trials. So you guys, Jessica, hit us. What are the overall survival updates at 5 years from Keynote 671?
So the 5-year survival improvement is about 10%, from 53 to 64% 5-year overall survival. And this is predominantly a stage 3 population. So that is really impressive in my opinion. The hazard ratio here is 0.74. So I think it's really impressive. I guess one thing that I'm going to ask Christine about, or maybe you about, it's almost identical to Checkmate 816.
That is an
So we have
excellent point.
two approaches, two drugs that seem very similar. Christine, how do you make this decision? How do you decide 816? I mean, granted, through a large portion of the world, there is no decision to be made. Only Checkmate 816 is approved, so it's easy. But here in the US, we have so many approved regimes. And this, we have this kind of nearly identical 5-year overall survival.
Absolutely. I think this is one of the hardest conversations that I have with patients in clinic is seeing them back after you take out their tumor, Jessica, and what do we do now? Because as the FDA has so well pointed out in the last few years, one thing these trials did not have from the get-go was contribution of components. So is all of the benefit that we're seeing in this 5-year survival from the neoadjuvant chemoimmunotherapy, is the adjuvant immunotherapy actually adding anything? Because these trials were not designed to answer that question for us. And so generally what we're doing right now is I will talk to patients before they start any treatment about you're going to have your neoadjuvant chemoimmunotherapy. And at time of surgery, we're going to get a ton of information back about how well your tumor responded. And if patients do have a pathologic complete response, their recurrence risk is very low. It's 10 to 20% across trials. So for those patients with a pathologic complete response, I am not adding additional adjuvant immunotherapy. The harder ones are the patients who don't have a past CR. And there we kind of talk about the risks and benefits of adding additional IO, because unfortunately right now we're in a very data-free zone. And whether or not that's contributing, we unfortunately really don't know given what we have at hand.
Very challenging space right now. And it's really interesting that you mention about the contribution of components, because it seems to me that there's a big trend right now with study design and sort of FDA asking for trials specifically to be structured so that we can start to answer questions in that way.
Absolutely. And I think it's a great thing, but also a tough thing, quite frankly, from a practical perspective. So here with Keynote 671, 400 patients were included in both arms of the trial. So if you're going to design a trial where you now need a third arm trying to figure out what's the neoadjuvant versus the adjuvant, your numbers have blown up from an 800 patient trial to a 1,200 patient trial or even higher. And so it makes it practically much more difficult to get these trials done and get them done in a timely fashion.
Absolutely. So I do think our next goal is to take trials or aiming at trials which recruit after surgery or which randomize after surgery. So taking that past CR and saying, okay, is the question, which I think the question is, more or none at that point, and then taking those with residual disease and doing a whole separate trial, because you can't enroll everybody at the beginning anymore. That pivot point of past CR is just too important.
Absolutely. This is where I think the cooperative groups are really going to shine. Right now, there's several cooperative group trials in this space, and I think this is where they can really help us answer these questions.
Because pharma's not going to answer the question, drug or no drugs. That's why the cooperative groups exist.
Do you know, I have to say, though, one of the areas that I'm so grateful that we are seeing some of these trials emerge is for the patients who have zero response, because to be honest, it feels really bad saying, hey, we're going to give you just immunotherapy afterwards. And we already know the chemoimmunotherapy didn't work. And so we're potentially proposing toxicity with objectively zero evidence of benefit. And so some of these escalation trials, I think, are going to be really exciting in that, exactly as you mentioned, Jessica, that post-randomization, that post-surgical randomization based on pathology, which is now sort of a linchpin part of really what we as surgeons are contributing to, and really an important part for our pathologists.
Yeah, there's so much in the middle of what we do now. And, past CR is a big deal. We talk a lot about, expertise in terms of surgery and expertise in terms of medical oncology. Let me tell you, expertise in terms of pathology is now a super big deal because, while it's easy to see past CR on a slide, it's hard to prove it in a 4-centimeter tumor. You've got to look at a lot of slides. And I just don't know that happens in every small pathology department throughout the country. So it's really important now. Pathologists are at the center of tumor board a lot.
Unquestionably, a lot of organizations, ISLC is one of them, are creating more intensive pathologic guidelines, even positive nodes, the number of N1 nodes that can exist within a specimen. I think there really is and needs to be a big push right now on having experts in lung pathology as often as we can in every institution to help answer that question and make sure we're prescribing the right adjuvant therapies for our patients.
I know I always die when I give someone a lobe and they found no lymph nodes. There's a lot of nodes.
Absolutely.
I don't want to hear there are no 12s or 13s. There's probably 50 or 60.
Absolutely. And really, truly, that could be the difference in the future of treatment versus no treatment, recurrence potentially versus no recurrence.
Yeah.
So Christine, you and I just got back from the North American Lung Cancer Conference, and one of my favorite debates from that conference was bringing everybody together to actually talk about past CR. And it really does seem, sort of in light of some of these major presentations this year, that more and more people, just like you're doing in your clinic, are feeling much more comfortable for our past CRs just stopping therapy. But we're not seeing that nimbleness necessarily mirrored across the country. How can we all help to support patients really across our nation with this very, very rapid pace of discovery, of change, of information? We're lucky to have a lot of leaders in oncology who do a lot of education, in surgery who do a lot of education. What messages should all of us, everybody listening to this podcast, be taking home as they're thinking about treating patients with immunotherapy in the perioperative space?
Excellent question, Erin. And, I think, unfortunately, the lung cancer advocacy community has often been behind some of our other advocacy groups because our survival numbers were so much worse. We didn't have the same number of survivors ready to pound the pavement and to, advocate for other patients about what treatment they should be getting. If your doctor tells you you need this, do you really? Here are the questions to ask. And fortunately, with these amazing trials that we've talked about today, we really are moving the bar from cure. And my hope is that we will have more survivors who are able to actively kind of get out there and advocate for other patients about issues like overtreatment, quality of life, toxicities from drugs, chronic toxicities. So hopefully we're swinging in the right direction.
I love that. Jessica, any concluding thoughts on Keynote 671 before we move into our final abstract?
I thought it was really impressive. I love seeing a 5-year update. They did actually give us great quality of life. The boringest slide ever, according to Marina Garasino, flat lines. This is well tolerated medicine. Again, not a lot of adverse events, not a lot of discontinuation. I think these are real. So if people need that year, I want to give it to them. But I do think our next step is figuring out who needs it and who doesn't need it. Because even if the drug is well tolerated, it doesn't come without financial toxicity.
Absolutely. Many types of toxicity.
Many types of toxicity. Our GDP is the next one.
Okay, so not that I should choose favorites, but I sort of saved one of the abstracts that I was personally most excited about for last, and presentations that I have been so excitedly waiting for, and that is the MDT Bridge trial. Admittedly,
Surgeon-friendly trial.
yes, this is such a great trial because, gosh, Jessica, how often are we looking at a patient in tumor board and we are asked in a 2-minute period to determine resectability, operability? We've never met the patient. We need so many additional studies to try to help make this decision. But we also know that this is going to potentially delay us getting started on therapy. And time is really important. And I don't think we talk about that enough, right? We say, hey, it's so important to get all these pieces so we can make the right decisions for patients. But waiting 6 weeks, 8 weeks, 10 weeks, 12 weeks before we're doing anything. There's a lot of studies coming out. They're small, they're single center, but some of them suggesting our timeline needs to be shortened to 4 weeks or less. And so this trial to me is a gift to surgeons to allow us to do workups. Give me your thoughts. Tell us about this trial schema. Share with all of our listeners why we're so excited about it.
We are excited. So this is kind of different trial design. It's asking a really different question, but it has to do with the dramatic responses we see to chemoimmunotherapy.
Yep.
You know, a 24% complete response rate is really dramatically different to what we've seen before. And so it's really asking, can we make unresectable or borderline resectable patients resectable? You know, we talk about, we determine resectability by technically, can I do an R0 resection? And physiologically, can the patient live through that? Are they healthy enough? Well, now we're adding one more. We're adding response. Will their tumor respond? What's the biology of their tumor? So I think it's really pretty exciting. And so the way the trial was designed, it was for patients with either resectable or maybe resectable, one
Borderline.
B, no ALK or EGFR. And they were then started on, it was just a phase 2, it's a single arm trial. They were started on 2 cycles of chemo plus durvalumab. And then after 2 cycles, they came back to their tumor board and they reassessed them from top to bottom. And then, made it, that was including, some places they rebiopsied lymph nodes and such. But then they made their decision. Their final decision was kind of made then: surgery or no surgery. They were going to go to surgery. They got another 1 to 2 cycles of induction chemoimmunotherapy and went on to resection. If at 2 cycles they were deemed they're not going to make it, they had what I would call the off-ramp or the pivot point. And the off-ramp was concurrent chemoradiotherapy followed by durvalumab. The Pacific regimen, which has been well accepted and is really well tolerated, is our standard of care. And they went from there. So I think it's an important concept. One, it's a new treatment for unresectable disease. Can we give 2 cycles of induction and then safely go on to Pacific? And there have been a bunch of phase 2 trials in the unresectable space, which have shown that that's very tolerable and works really well and works better than anywhere else we put the immunotherapy in concurrent chemo-rads. So I'm excited about that arm and the proof that off-ramp is safe, tolerable, and people can get through it. But then that on-ramp is really exciting because we took a whole bunch of patients and lo and behold, they were resected. And the resection data, the primary outcome of this trial is not survival, it's resectability. With things like overall survival and disease-free survival as secondary endpoints. Now, granted, a lot of the patients who went into this was just their first kind of planned analysis, subset analysis. It was really just for efficacy. Can we do this weird design and will we learn anything from it? And so they really had 2 cohorts, those which they thought were resectable, and then those which they thought were really borderline. And they were more resectable than borderline resectable patients. But after 88 patients, the overwhelming 72 of them went to surgery, which is like, I don't know, that's like 85% of patients went to surgery, which matches up with what we saw in every single one of our previous chemo IO trials. So I do think this concept of we've gotten better at getting our patients to surgery is very much true, because here was a higher risk population and we still got them to surgery. And of those who were considered borderline, like over 70% went to surgery. And those who didn't, I think there were like 12 patients. 8 of them started, concurrent chemorads. So it wasn't like they didn't get their good treatment. So I thought this was really exciting. I think surgeons like it. One, more patients to surgery. We always love that. But also it's very much tailored at changing our treatment, our evaluation, and really trying to use response. And I think, Christine and I just had another patient recently who had, came to us with a high PD-L1, and I just resected him, and he was a past CR who had a dramatic response. I think when we see those patients with high PD-L1, I think about this trial. These are the patients who I really think that their response is going to allow us to get here. One thing I do have to say about the trial, this was done within a team. And I think that's so important. And I'm waiting for the patient I get from the community who's gotten their 4 cycles and now they want me to see him for the first time. That's not what this trial is about. That's what they did. I don't know, there was a paper recently that came out of Penn that said 40% of our patients who go on induction don't go on to surgery. And that's because the surgeons don't see them up front. So this is a team approach. The team has to do it all together. And I mean, we have to all be on board. You can't sell the patient that, oh, well, no surgery, you're done, see ya. Like, it has to be, we're going to pick the best treatment for you. And it might be radiation or it might be surgery. We'll see what it looks like in 2 cycles.
Well, and I agree. I think it was really rich in that we say, hey guys, we have 2 really great local control options. We're not always absolutely sure at outset when you arrive which one is going to be most efficacious in your case. And so we get the gift of time on these beautiful treatments that Christine can deliver, our chemoimmunotherapy, and we have the gift of repeating scans or getting a better scan if we have one of those, 1 centimeter slice scans that are just absolutely awful, and you need an MRI to check for invasion in a particular area. You have the gift of time for smoking cessation, pulmonary rehab to improve the health of your patient, the physical fitness of your patient heading into a potential surgery. So it gives us that gift of time for decision making up front. Now, Christine, one of the things that a lot of people had questions about when we talk about this trial is, why didn't we do this sooner? And there seemed to me like there's a lot of reticence at first of actually putting immunotherapy before radiation. Can you talk to me a little bit about those concerns, and are those alleviated with this trial? Where are we with some of that? And I acknowledge you are not a radiation oncologist, so I'm putting a little bit on the spot, but I know you have those conversations with our radiation oncology colleagues. So what can you share with us?
Well, I would love to answer this question because immunotherapy and radiation is one of my huge areas of research in the metastatic setting. But I think where a lot of the concern has come from is that the trials that looked at concurrent chemoimmunotherapy with curative intent radiation actually have not shown a benefit and have in fact trended toward a detriment. And some of the hypotheses that we've seen is that when you're including such large field radiation with concurrent chemorads, you're going to obliterate a lot of the lymph nodes intentionally, because that's where much of the cancer is. But that may be really stifling the ability of the body to mount an immune response with this immunotherapy that you're giving concurrently. And so I think that's been a lot of the hesitation. Where I think this trial shows a much different approach is that you're giving the chemoimmunotherapy before. So not concurrent, but before. And because of the amazing response rates that we can see, in this trial, we saw radiographic response rates of 60%. That can also help with the radiation. If you're massively shrinking the radiation field and what needs to be included, that can lead to long-term improvement in patient outcomes as well. And so I think the timing is very important.
Yeah, I agree. My background in the NRG, we had several trials which were negative of putting the immunotherapy with the chemorads. That's a disaster. And I mean, some of us saw it coming. You are radiating the entire blood pool too. So those T cells are like, we're here, and then boom, kill. But I think doing it before, like I said, I think there have been 3 phase 2 trials that have proven this is safe. It shrinks the tumor. Those people have good responses, get less, they get a much smaller field. And I think it's going to be the next wave in non-operative stage 3A for sure, or non-operative stage 3.
So Jessica, I want to circle back to one of the stats that you shared before, because I want to highlight this again, just in case people missed it. So 84 patients included in this trial. So admittedly, it's not a huge trial, right? This is phase 2. This is exploratory. We're figuring out, can we do this safely? And 56 patients were deemed resectable up front. 95% of those went to surgery. That's massive, right? Massive.
93, but you're right. Like everybody, I think there was one patient who didn't. So yeah.
Exactly.
So you're right. And I think we've seen this in our practice. In the beginning, when we did chemoimmunotherapy and then resection, we were on BMS trials. I remember the patients who did resection. I definitely had one in 816, and I definitely had one in 717. They were my patients. But I mean, it's been a while since we have had one where we didn't see it coming. We do use the bridge approach, and we've had several where we're like, I don't know, what do you think? And we all get together. But it has been a long time since we've had a patient who we thought was resectable, who we gave them immunotherapy, and they didn't get to surgery. So we, as a group, have learned. And we've learned who is good for this and who isn't. And I would say, I don't know if Christine agrees with me or not, I think it's so much about performance status. I think when they fall off, it's always because they were performance status 1, maybe 1.5. And by the time it was done,
1.8, 1.9. Yeah.
Tickling 2. They're tickling 2.
I think for sure we learned that like the rollator sign was going to be negative. If they come in with the rollator pre-op, it's not happening.
Or they're going to be, we can do it, we can shrink it. I think we also, we get more enthusiastic about high PD-L1, less enthusiastic about low. We've just gotten better at feeling this out. And like I say, I would say our rates right now have got to be above 90, if not, 95%. So it's nice to see that prospectively in this trial.
95%. And even 82% for borderline resectable. So these are people we weren't sure. 82% are going on to have a highly successful surgery and very high rates of R0 resection, right? 68 out of 72 patients who went to surgery had R0 resections. So we're doing a great job choosing. We're doing a great job downstaging patients. Christine, to your point, more than 60% of patients had radiographic downstaging. 27% of patients had a past CR. This is working really efficaciously. So you guys, you have to know the next question that everybody's going to ask is, and you've alluded to this a little bit before, Jessica, do we stop at borderline, or do we start kind of eking that a little bit further and actually try to start converting the truly unresectable patients into unresectable? There are trials that are doing this. What space should that exist in?
I don't know. So the biggest, I think, discussion point there is probably the end of the patients.
Yeah.
Can we, N3 is the next horizon. Can we make them resectable? And there are, I sit on the committee for the NCI that looks at these trials. There's a lot of people who want to look at that. Yeah. So what would it take for us to say an N3 patient could go on to resection? If we re-EBUS them or did a mediastinoscopy and they were negative, could we operate? I don't know. I think, for patients who have a high PD-L1 and a good performance status, is it worth trying it? It's probably reasonable. My other question is, it's how much response do you need to see? And the patient obviously has to, to have N3 disease and still have a resectable tumor on the other side is not always realistic. N3 disease sometimes comes with effusions and other things.
Absolutely.
But I think, we are incorporating, surgery into oligometastatic patients, right?
Yes.
It's a spectrum. And I think trying to get better at recognizing how well is the systemic therapy going to work? What's the patient's true performance status? What can they endure? All of that goes into it. But I think increased recognition that it's a spectrum is going to be important.
And importantly, for all the surgeons who are extremely worried about us getting completely kicked out of the field with all those beautiful drugs, you guys, we have a more important place than ever. And I think really, truly, as I sit all of these incredible meetings this year and hear about all of these incredible new regimens, I think really, truly, I am inspired to continue to try to raise the surgical game so we can continue to provide higher quality surgery, as minimally invasive as possible, get patients home faster, minimize the perioperative complications. How can we continue to contribute really meaningfully to these patients' outcomes? Beyond just an R0 resection, we need to be thinking about every single piece of this.
Right. How we fit within this whole treatment schema, because it's going to be fewer and fewer patients who just see us.
Yes. Yeah. Absolutely. Absolutely. So MDT Bridge, super, super, super exciting. I think absolutely is going to change how we think about stage 3 disease. What are your final thoughts, Jessica, about MDT Bridge? Where do you want to see this go next? How do we structure the phase 3? What's the next step?
Ooh, God, the phase 3 is going to be interesting here because I just what's your control R? It's going to be interesting. I don't know what the phase 3 is here, and whether the phase 2 is enough to change care. My bet is that it is, because, Erin, it gets down to this incredibly nebulous thing, and that's resectability. As surgeons, we have, I don't want to say we failed at, really defining resectability, but it is not. It varies from patient to patient, from surgeon to surgeon, and from institution to institution. Yeah. I think it's hard. That was when this trial first started, I'm like, how are we going to do this? What's resectable to me may not be resectable to you, and the other way around. But I do think it's important that we've really pushed surgeons to do a better job on determining that. And I think we do need to do a better job at really defining resectability. And you're right, it is okay to vary from place to place, but maybe we need to define the ground rules.
Well, the funniest part of it is this year alone, we've seen 3 publications come out from the STS, the ISLC, and ESMO trying to define resectability. And the funniest part is in the whole middle part of the map, which is these patient populations, it says potentially resectable, multidisciplinary tumor board discussion.
But I do think that's one of the keys, having, having the whole team on board when you make a decision is really important for any of these borderline patients. And that's why you're right. What I think is resectable at the University of Chicago may be really different from what happens in a smaller hospital where they don't have all the same resources. They can't throw someone on ECMO if they get in trouble in the OR. They just don't have as many things that they can do that they change.
You're right. It's the perioperative phase is just as important. Every single part of the team is critical. Our oncology teams, our radiation teams, our physical therapists, our dietitians, our nurses taking care of our postoperative patients. You can have a technically perfect surgery and still have a bad outcome if you walk around on post-op day 1 and your patient's in recumbent position eating lunch and they aspirate. So it's all of these little things about how do we set up a patient for success, a program for success, and how do we make sure that patients are being cared for as close to home, which I think is really important, but also making sure that these technically complicated procedures are being potentially done in the right place, / how do we get surgeons the tools that they need to help these patients and build up their programs to be able to handle them, if that's something that they're passionate about and interested about, even if it is a small hospital.
Yeah, I agree. And I definitely think that there are patients who the priority is being treated at home, and that's a beautiful, wonderful thing. And there might be some people who think, oh, is there more? And is it worth traveling 50 miles? For some of them, it probably is. But I don't know if we all take the time to ask our patient, what is your priority? What's important to you as we go down this journey with this, especially if they have stage 3? It's such a complicated disease. There are so many options. It's rare that we say, what are your priorities? And I think that in stage 3, that's something we should be asking.
Absolutely. Christine, how are you thinking about MDT Bridge post ESMO in your practice? Is this changing how you guys are having some of your conversations with the radiation oncology team? And I know you guys also have these incredible outreach tumor boards to help many of the hospitals in your region. How is this influencing and changing care?
So I think in some ways, MDT Bridge is actually also just practice affirming. I think a lot of us were doing much of this already where we have these patients with large tumors, but PDL 90% and they're pretty fit. Like, I'm feeling good about this one. And so I think it'll be practice affirming for those patients. But I think you're right. I think, make sure the radiation oncologist is still involved from the beginning. They may need to bail, Aditya Jalori may need to bail Jessica and I out at some point. And so keeping them involved, making sure that they've also met the patient, if that's, potentially where they're going to end up, I think is important. And just increasing across team collaboration, as Jessica had said.
I love that.
I also admit, Erin, at our institution, we have not opened this trial, but we have the bridge approach. So we have
I know. We keep talking about it too, because we were also not a site, but it was not uncommon for us to use this regimen, knowing that this trial was ongoing. And sometimes it was sort of an accident. It was a patient was started on therapy. They weren't in with the surgeon or with the radiation oncologist. They hadn't had PFTs, things like that. As our community continues to learn about all of these great opportunities. And then in some cases, this was actually very intentional, just to see if we could get the response we were hoping we could get. And we did. You guys, this has been such an incredible discussion. I cannot thank you both enough. So let's dive into some sort of wrap-up concluding thoughts. Jessica, I'm going to pitch the first question to you. When you think about this whole last year, really capped by this incredible ESMO meeting, what were some of the biggest trends, themes? What do you think was most transformative for our field of thoracic oncology?
So I think the most important things we saw this year were the 5-year survivals, 5-year reports from Checkmate 816 and Keynote 671. I think that has really cemented this new standard of care. And I think that paired with Adura from last year or 2 years ago, there's just not a way that you can have a patient with stage 2 or 3 disease and not be treating them in this manner. And I think it behooves every surgeon to understand these medicines, to understand who should be on these trials, and to make sure, in past years or past decades, we were really bad about getting patients to adjuvant or neoadjuvant treatments. This has to be front of mind for everybody. And I'm really disappointed when I still see patients coming for second opinions or from the community with clear stage 2 or 3 disease that someone was going to take to the OR without one of these agents or one of these regimens. It's just not appropriate anymore. I really do believe that.
Christine, what do you think is the next hot thing we need to be looking for moving into the neoadjuvant, the adjuvant, the early stage space in general?
So since Jessica did such a good job covering immunotherapy, I'll take targeted therapies. So I think we're right now at a point where we have adjuvant, EGFR, and ALK is what's FDA approved. So I think we're going to expand into the neoadjuvant setting. We need a little bit more data for neoadora as far as durability, but I'm very optimistic. And then I think we also just need to increase that to all of the other biomarkers. KRAS G12C, ROS1, these are all targets that have perioperative, neoadjuvant, or adjuvant approaches under study right now. So I think expanding those options to all of our targeted therapies patients is really going to move the needle.
I'm so glad you mentioned in particular about KRAS. This is a patient population that have a mutation that often portends a worse outcome. And I worry that I see trends of these trials not making it to completion, closing early with a lot of these targeted therapies and perhaps more unique biomarkers that many surgeons aren't as familiar with. So please, 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 to all our incredible listeners, talk to your medical oncologist all the time, find out what clinical trials are open, find out which targets are being evaluated. We need to make sure we're sending patients for these trials. A lot of these patients are coming to us first. We need to make sure that we're enrolling them so we can sort out how we can continue to move the needle on survival for our early stage patients and continue to enhance our disease-free survivals.
Absolutely.
If you guys can each give me one concluding thought about your favorite piece that you want everybody to take home from the 4 topics that we discussed today. Christine, I'm going to let you go first so that you can choose the first one this time, and Jessica, I'll come to you last.
I would say number one take-home message is biomarker testing should be offered for all patients at this point. I think you had already mentioned a call for your surgeons to get in and get comfortable with biomarker testing. And I think it's a shared responsibility of all of us to make sure that this is being sent, being reviewed, and potentially being acted upon.
I love that. Jessica?
So my takeaway from this year and the past 5 years is everyone needs to have a medical oncologist as their best friend. As you have listened to here, everything I know, I have learned from Dr. Bestvina. And I think it's essential. We all need that partner. And it's been amazing doing this journey with her.
Oh, I love that. I love that. Yes, no, you guys, team sport, it's so exciting. And we have the best colleagues to get to spend time with. So
lucky. I similarly would like to express my gratitude outside of the podcast recording. So thank you for being my partner.
absolutely. What incredible concluding statements and an incredible call to action for all of our colleagues. Dr. Donington, Dr. Bestvina, thank you so much for joining me today, for helping me to translate these findings into these really powerful thoracic oncology insights. For our amazing listeners, you can find more information and related resources at sts.org and in the show notes. Until next time, I'm Dr. Erin Gillaspie, the podcast host at the Society of Thoracic Surgeons. Please make sure to follow the 2025 Best of Lung Cancer Science podcast special edition series, which is now available on all popular listening platforms, including Apple, Spotify, and iHeart. And please don't forget to follow me on Thinking Thoracic, our STS podcast that offers candid conversations about the latest advancements and challenges in thoracic surgery. The podcast is also available on all your favorite listening platforms. Thank you guys so much and look forward to seeing you soon. Happy New Year.